Yeah. So it's 3, 2, 1. We are live to the audience platform. We can start this meeting. Over to you, sir.
Good evening. I'm Dr. Manoj Goel from Delhi, and I welcome you all to this OAD webinar series organized by Indian Chess Society, headed by the President, Dr. Sandeep Salvi, Dr. Amita Nene, who is the chair of the ICS at the moment, and Dr. Raja Dev, who is the secretary of ICS. And these meetings are brought about by the immense effort of Dr. Amita Nene, and we are extremely grateful to her for organizing these meetings, and they are proving to be extremely useful, not only for the students, but also for the specialists and even the senior faculty members. And I have been a part of these meetings a couple of times and found to be very informative. And honestly, I learned a lot from them. And today we have got a wonderful opportunity to, discuss a topic which we know has been, fascinating for many, many years. And that is about allergic bronchopulmonary aspergillosis, or ABPA. And we're very fortunate that we have an excellent panel of experts to discuss this topic who will share their experience. And again, it's going to be a good learning experience, especially for me, and that I can vouch for. So coming to the topic, we know that the allergic bronchopulmonary aspergillosis is an allergic lung disorder, which is caused by the hypersensitivity reaction against the Aspergillus fumigatus, which colonizes the airways of patients with asthma or cystic fibrosis. But having said that, the ABPA can occur in patients who do not have asthma or who do not have cystic fibrosis, and many other conditions ABPA can be there. But today our focus would be ABPA with asthma, because that is the commonest, entity that we encounter in a day-to-day practice. And patients with APA would commonly manifest with poor asthma control, recurrent pulmonary opacities, recurrent chest infections and hemoptysis, and various other complications. Also, the loss in lung functions over a period of time if not treated appropriately. So, good thing about ABPA is that remission is achieved in majority of the patients with treatment. But bad thing is that despite good, therapeutic management of these patients, around 45% of the patients, even 50% of the patients relapse. And that is a big problem. And that is the biggest challenge. And that's why this makes this disease very, very fascinating for the pulmonologist, because it really gives you a challenge to, control ABPA. The other thing which is challenging about ABPA is it would generally occur in patients with severe asthma or difficult to control asthma, which in itself is a challenge. So to simplify the management of ABPA and to simplify the understanding of ABPA, we've got excellent panel of experts. And of course, they don't need any introduction. They are very well known all over India. So I think it would be nice if I request all my panelists to introduce themselves. So I will start with Dr. Khushbu Pilania. So Dr. Khushbu Pilania, welcome. Please introduce yourself. Dr. Khushbu.
Hello, yeah, hi. Thank you, sir. So I am Dr. Khushbu Pilania. I am a consultant radiologist working with Picture This by Chankaria at Mumbai, and I work at Eisen Imaging and Interventions at Noida. So I'm predominantly based out of Delhi NCR, that is Noida, and work at Eisen Imaging and Interventions here. I have a special interest in chest radiology. And it's a great privilege and honor to be a part of this meeting and to be learning from the senior chest faculty that I have around me. I'm sorry my video is not on because I'm not in a proper place to be putting it ahead right now.
Thank you, Khushbu. You are an icon in respiratory radiology and everybody knows you. So we are very grateful that you are today on board. Now, I would request Dr. Nagarjuna Mataru to please introduce himself. Dr. Nagarjuna.
Hi, everybody. I'm Dr. Nagarjuna. So I'm currently practicing in Hyderabad. I head one of the branches of Yashoda Hospitals, which is the high-tech city. And I'm happy to be a part of this webinar, and I look forward to learn a lot from all the panelists here.
So Dr. Nagarjuna is one of the best interventional pulmonologists in the country. He is one of the pillars of, interventional pulmonology in the city of Hyderabad. And we keep seeing his videos and the excellent work that he does in the pulmonary interventions. Welcome, Dr. Nagarjuna.
Thank you so much, sir.
My extreme privilege is to ask Dr. Barnali Datta to kindly introduce herself. Dr. Barnali.
Ma'am, can you please unmute yourself? Yeah.
I'm Dr. Barnali Datta. I work as Director of Respiratory Medicine in Medanta, the Medicity. I look forward to engaging in this wonderful event on ABPA.
Barnali is actually doing a pivotal work in tuberculosis in the state of Haryana. And in fact, he's a brand ambassador of TB control in Haryana. And we are extremely pleased to have you on board, madam. Thank you so much. Dr. A.R. Paramais, could you please introduce yourself?
Good evening, all. I'm Dr. Parmesh Iyer. I am based in Cochin and I am heading the Department of Pulmonary Medicine at Lisi Hospital. It's a tertiary care hospital, and I am thankful to ICS and Manoj sir for giving me the opportunity. Thank you.
So, Dr. Paramais has worked for considerable time in Delhi and NCR, and now he is a big name in the country. And he'll be organizing the BronchoCon 2024 in the city of Kochi, and we look forward to him meeting there. And before that, of course, many times in various meetings as well. So thank you, Dr. A.R. Parmais, for joining us. And then I would request Dr. Kamlesh Pandey to kindly introduce himself. Dr. Kamlesh. Dr. Kamlesh, please unmute yourself. Yeah.
Yes.
Yes, please introduce yourself, Dr. Kamlesh.
Yes, sir. I'm Dr. Kamlesh Pandey. I'm practicing in Mumbai. I'm a consultant pulmonologist at Wockhardt Hospital. Hello, sir. Am I audible?
Yes, please.
Yeah, I'm consultant pulmonologist working at Wockhardt Hospital and Inspire Chest Clinic and Research Center in Mumbai. And I'm privileged to be a part of this panel discussion, sir. Thank you, sir.
Thank you, Dr. Kamlesh. And you're representing the whole of the Western India today in the meeting, and really pleased to have you on board. And not last but not the least, Dr. Shivani Swami, please introduce yourself.
Good evening, everybody. I'm Dr. Shivani Swami. I'm based out of Jaipur, and currently I'm heading the Respiratory and Sleep Department at Narayana Multi-Speciality Hospital, Jaipur. And I'm very thankful to ICS and especially Amita ma'am for giving me the opportunity to be here. I'm really looking forward to this discussion.
Dr. Shivani has also worked in Delhi and NCR and has published a couple of books also. And she's one of the authorities in sleep medicine. And very grateful to have you on board, Dr. Shivani, please. So with the kind introduction of all the experts, I would now request Dr. Khushbu Pilania to please proceed with her talk on radiology in allergic bronchopulmonary aspergillosis. Please load your slides, ma'am. Yeah.
Am I audible?
Yes,
ma'am, you're audible and visible. Slides are also there, ma'am. Thank you.
All right. So at the outset, I would again like to thank the OAD for giving me this opportunity, Amita ma'am for giving me this opportunity, and Dr. Manoj Goyal for that kind introduction. It's a huge privilege to be a part of this program where I'm talking to the best chest physicians across the country. And believe me, I learn more than whatever I am giving out of these talks. So I'll always it's a learning for me. So what we will be discussing today is radiology in allergic bronchopulmonary aspergillosis. So as it's already been discussed and said that there are no such rules that certain finding is, if it is there, it has to be an ABPA. It is always a combination. It's a combination of the radiology, of the clinical picture, of the blood workup. But yes, there are certain findings which, if we see, we know how to prognosticate the patient. We know how the management should go ahead. So that is what we will be discussing. As this was already highlighted by Dr. Manoj Goyal, that allergic bronchopulmonary aspergillosis is an immune-mediated hypersensitive allergic response to Aspergillus fumigatus in predisposed individuals with asthma or cystic fibrosis. So, well, this is well known. And the important points are to understand that it's a hypersensitive allergic response. It is not an invasive disease. It's a rather benign and an indolent disease. And it has a predisposition for patients with asthma or cystic fibrosis. So I'm stressing on this just to say that the clinical scenario of the patient is important in the diagnosis. So the three important pillars in diagnosis of ABPA is the clinical picture, the immunological workup, and the radiological workup. So it usually occurs in patients with asthma and cystic fibrosis, though as said earlier, there is no rule. It can occur otherwise also. But the majority of the patients who have ABPA have either a background asthma or cystic fibrosis. The prevalence is more common in patients with cystic fibrosis, but the overall incidence is more in patients with asthma because asthma is more prevalent overall. Amongst the blood workup, the patients present with blood eosinophilia and reactivity to Aspergillus antigen in the form of increased IgG or IgE levels. When we talk of radiology, which is the context of this particular talk, we see pulmonary opacities and central bronchiectasis, which are amongst the typical pictures, typical radiological findings in ABPA. So the appearance in the current case scenario is more dependent upon what we see on the CT scan. Yes, radiographs also have a role, but in the current era where CT is no longer a limitation with respect to the availability, it's a better idea to go ahead with an HRCT to figure out the exact status of the disease. Before going on the CT findings, let us just go through these diagnostic criteria, which I'm sure we'll be discussing over again. Just to the only idea to talk about this is that in 1977, when this criteria was put ahead, amongst the primary criteria, there were two features, the 6 and 7, history of transient or fixed lung infiltrates and proximal bronchiectasis. These two features were pertaining to the radiology. Rest all were with respect to the blood and the immunological workup. Similarly, the 2013 ISHAM group criteria, again, only amongst the supportive criteria, we saw these consistent radiographic opacities. So I am just highlighting again that ABPA is a disease wherein the clinical context is much, much more important than what we are seeing on the CT scan. What we are seeing on the CT scan is just to triage a patient, to prognosticate the patient more than making an upfront diagnosis or refuting or confirming the presence of ABPA. What are the characteristic CT findings that we see in a patient with ABPA? We see central bronchiectasis, that is bronchiectasis which is towards the hila and not so much towards the periphery. You see mucus plugging, that is in these dilated bronchi due to reaction to the aspergillus, there is extensive mucus formation which gets trapped within the bronchi. We have the high attenuation mucus sign, and amongst the other radiological findings due to the central bronchiectasis and mucus plugging, you can see atelectasis, areas of consolidation, then there can be distal small airways disease leading to air trapping, and there can be pleural involvement. Pleural involvement can be in the form of effusion or pneumothorax either. So the other radiological findings are amongst the findings which you see with most of the other infections in the lung. So these are nothing very characteristic, but the top three findings, that is the central bronchiectasis, mucus plugging, and high attenuation mucus signs, are more sensitive and specific towards ABPA. When you talk of central bronchiectasis, there is a specific type of bronchiectasis which is specific for ABPA, which is the central bronchiectasis. What is central bronchiectasis? You see the central involvement, which means that the medial 2/3 or the medial half of the lung is involved more than the peripheral. When you see this entire bronchiectasis is confined towards the hila, the periphery is spared. When you see such tubular bronchiectasis emanating from the hila, this is central bronchiectasis. The typical central bronchiectasis of an ABPA has an upper lobe involvement. It should usually involve 3 or more lobes. If it's a solitary single lobe involvement, then you should think of other proximal causes like some proximal bronchial obstruction leading to bronchiectasis, some past history of insult in that single lobe. For ABPA, the characteristic finding is 3 or more lobe involvement, central bronchiectasis, and an upper zone predilection. But yes, if the clinical picture and immunological workup is suggestive, and even if you have a lower lobe bronchiectasis, then also it is considered amongst the diagnostic criteria for ABPA. So this is the very typical bronchiectasis that you see in a patient with ABPAs. It is a characteristic bronchiectasis that you see in a patient with ABPA. So if you see such a picture, central bronchiectasis, upper lobe predilection, in a known patient with asthma, this is highly, highly suggestive of allergic bronchopulmonary aspergillosis. What is mucus plugging? So amongst these dilated bronchi, you see that these are plugged. So this is definitely these tubular opacities. You see these tubular consolidations. When you see these tubular consolidations in the lung, something that you should be keeping in mind is possibly these are not consolidations, but these are dilated mucus-filled bronchus. So this dilated mucus-filled bronchus, when seen on the lung window, appear as consolidation. It is important to go back and look at the mediastinal windows and then scroll through the images to understand that these are dilated bronchi. I'll show that image well. We have over and over always talked about the high attenuation mucus. So yes, if these mucus, if the plugging within these bronchi is high attenuation, that is, it is white, then it means that it is highly pathognomonic for allergic bronchopulmonary aspergillosis, but that pathognomonic ham sign is seen in only 20% of the cases. So rest all the mucus is more hypodense. So it does not mean that if the dilated bronchi are filled with hypodense or a rather black looking mucus, it is not allergic bronchopulmonary aspergillosis. It still means and it still fits the criteria of allergic bronchopulmonary aspergillosis. So over time, when these fill in these dilated bronchus and when these persist, it leads into bronchocele, which are dilated bronchi, and the finger in glove sign. Another presentation of mucus plugging is centrilobular nodules. So when you see these centrilobular nodules, the way you see with TB, etc., in a patient with asthma towards the periphery, this is also more a sign of mucus plugging and due to allergic bronchopulmonary aspergillosis rather than any other infective bronchiolitis. So this is what I was talking about, the high attenuation mucus. So in these two dilated bronchi, you see that this mucus is bright. So how do you compare? You compare the shade of this this area with the shade of these paraspinal muscles. So these are the paraspinal muscles. If the shade within these dilated bronchi is brighter, it is more white, then we call it a high attenuation mucus sign. For example, if you see within these bronchi, the shade is not as white. It is paralleling, similar, or in some cases, it can be lesser. Then in these cases, this is the hypodense mucus. So as I stated, more commonly in patients with ABPA, you will see the hypodense mucus rather than the high attenuating or the hyperdense mucus. But if you see the high attenuation mucus in a dilated bronchus, it becomes pathognomonic for allergic bronchopulmonary aspergillosis. But again, stressing on the fact that it is seen in only 20% of the patients, and the presence of this high attenuation mucus is due to the calcium salts and other metals which are secreted by the fungus. So these fungus secrete these particular elements, and which leads to the high attenuation mucus. This is what we were talking about, the typical finger in glove signs. So you see these finger in glove signs. This is described more with respect to the X-rays. So when in X-rays you see these finger in glove sign, these means that these are dilated mucus plug bronchus. They are often fleeting. So you see them at some places, then they resolve from those places, appear in another places. And this is what we call the fleeting opacities of allergic bronchopulmonary aspergillosis. Then when we were talking about the central airways, the centrilobular nodules. So in these cases, you are seeing these dilated bronchi, and at the periphery, you are seeing these clusters of centrilobular nodules. So you see these clusters of centrilobular nodules. So in a patient where there is a high suspicion of allergic bronchopulmonary aspergillosis, so for example, in a known asthmatic with proximal central bronchiectasis, like you see in this case, If you're seeing these distal centrilobular nodules, then these are more likely to be related to an active ABPA rather than to be related to an bronchiolitis associated with asthma or another infective bronchiolitis. So this is something that we need to keep in our mind, that if these findings are seen in a patient with central bronchiectasis, then they will be more likely associated with ABPA than with asthma-related follicular bronchiolitis. These are amongst the other radiological findings that you may see in a patient with allergic bronchopulmonary aspergillosis, but these are mostly sequel of the central bronchiectasis and the mucus plugging, which results in distal atelectasis. Then you see areas of consolidation, which suggest increase in the inflammation. Again, air trapping is due to the resultant secondary constrictive bronchiolitis because of the airways involvement and progressive airway dysfunction in that area. And as I said, pleural effusion and spontaneous pneumothorax may also be seen, but none of these findings are very typical of ABPA. The important thing which I've been stressing on is that HRCT of the chest can be normal in almost 1/3 of the patients suffering with ABPA. So these are labeled as serological ABPA, and thus this is one of the places where CT scan is not so much needed for diagnosis of ABPA, but more for prognosticating and staging what kind of a treatment needs to be given, how severe is the disease. So on the similar lines, the classification is that if it's a mild disease, which is a disease which is serologically positive but with normal radiology, when in a serologically positive case with typical clinical picture, you see some CT findings suggestive of ABPA, like central bronchiectasis, it becomes an ABPA-CB or a moderate disease. ABPA-CB HAM is a severe disease where, apart from the serological and the clinical picture, you are seeing central bronchiectasis with high attenuation mucus. So the importance of high attenuation mucus is not just that it is pathognomonic, but it also says that the disease is more severe. So we see the immunological severity as well as the risk of relapses. So the risk of relapses also increases progressively as we move from mild to moderate to severe. So the presence of HAM suggests that there is a high risk of relapse in that particular case. So that is why the importance of HAM is as a pathognomonic finding, and then to predict the immunological severity and the risk of relapse. Then going on the same lines, we also classify ABPA radiologically basis the stage in which we are seeing the disease at a particular point of time. Now, these staging is not that they follow a sequential order. It does not mean that an ABPA will go from stage 1 to 2 to 3 to 4 to 5. It just says that at any point of time, it can be in any of these 4 phases that we should be knowing about. Obviously, the 5th phase, that is the end stage ABPA, is the end stage phase, but the others do not follow any sequential order. We need to know about them because the treatment varies, and yet again, how the patient will respond varies depending upon the phase in which they are presenting. So acute phase is either a serological positive disease with normal radiological findings, or in cases where we are seeing some pulmonary infiltrates, mucoid impaction, mostly in the upper lobes. Remission is a phase where the infiltrates resorb. There is clearance of the mucoid impaction. So obviously it is a sequential phase. So when you see an acute phase and in the subsequent phase, you see this remission, then you know that there has been resolution of the disease. Exacerbation is where you see newer disease. You see more infiltrates, more mucoid impaction, new areas of involvement. Glucocorticoid dependent ABPA is when you see significant resolution of infiltrates or mucoid impaction, but with some fixed pulmonary opacities. And end stages when you see dilated bronchus, some fibrosis, and which also eventually lead to core pulmonary or pulmonary hypertension. So I will just go through this case, which shows how this disease shows a very typical waxing and waning course. So this was a 33-year-old with cough and expectoration, known case of asthma. The first CT scan done in December 2002 showed these areas of a patch of consolidation, which was in fact these dilated tubular bronchi with high attenuation mucus signs, the typical finger in glove appearance. So this was a focal patch of consolidation showing the acute phase of the disease. The patient again presented in September 2023, where corresponding to the same site where you were seeing the dilated high attenuation mucus sign, you see a large cavitatory consolidation. And then these central, you see the typical central bronchiectasis in the perihilar distribution, this in the upper lobes towards the lower lobe, superior segment of the lower lobe. So the background finding is very typical of a allergic bronchopulmonary aspergillosis related central bronchiectasis. And in this phase, you see a large area of consolidation. So this means that this patient is now in an exacerbation phase, and wherein you are seeing this increase in the disease activity, where earlier you were just seeing dilated bronchi, which has progressed to a consolidation. Then the patient presented again in August 2007, where you see a new patch of consolidation with an internal high attenuation mucus sign. So you see that the disease is kind of showing a fleeting progression. There are newer diseases appearing at newer areas. So it is still in the exacerbation phase where you're seeing new opacities, new consolidation, new ham signs at different sites. You're also seeing some pleural effusion. So definitely, currently also the patient is in an exacerbation phase. In May 2008, again, you see that other opacity has resolved, but this right lower zone opacity has progressed with high attenuation mucus seen here. So this is how the disease has been showing a kind of a course wherein it is moving from acute phase to exacerbation with areas of remission and newer disease at certain sites. So at this site, if you look, this consolidation appears more resolved or moving towards a chronic phase. However, you see yet another sign, new mucus plugging with ham in the left upper lobe. Over time, this is how the disease showed a waxing waning course with newer areas of consolidation, reappearance of the ham sign in the right middle lobe, which had gone in between and then reappeared. So this is how it is moving on with yet another newer area of consolidation and ham sign at the site where earlier there wasn't a consolidation. And eventually in May 2012, we see this kind of a picture where we see just a background bronchiectasis. We do not see any consolidation at present. I do not even see any ham sign or mucus plugging. So this is how the disease has progressed. And now finally we see a disease which is more towards a phase where we can also call it a fibrotic disease. And often there is so much of extensive fibrosis related to ABPA that it leads to a secondary pulmonary hypertension or core pulmonary. So what is the fate of an untreated ABPA? When a ABPA is not treated, the bronchiectasis goes on progressing, and because of these recurrent exacerbations, remissions, progressions, there is pulmonary fibrosis in the surrounding lung, and which eventually also leads to core pulmonale and pulmonary hypertension. It can lead to an end-stage fibrotic ABPA, and as I said, eventually a type 2 respiratory failure or right heart failure. Rarely, because these patients have been on immunosuppressants, there can be a picture which suggests that the disease has converted into an invasive aspergillosis. So if that happens, and in case you are seeing a consolidation which is not remitting on its own with the due course of treatment, this is something that we should be thinking of. Often the consolidations are a part of exacerbation of disease, but we need to figure out how exactly the background clinical picture is. So this is what is the fate, as I showed earlier, of an untreated ABPA. The background dilated bronchi with surrounding fibrosis in the lung parenchyma is what we see with an end-stage fibrotic ABPA. How is ABPA in cystic fibrosis? Slightly different. So what happens that in patients with cystic fibrosis, they are more prone to develop ABPA as compared to patients with asthma, but overall the incidence of cystic fibrosis is less. So most of the patients that we see with ABPA are asthmatic patients. In patients with cystic fibrosis, the background picture of the lung due to cystic fibrosis is the same as it is in patients with ABPA. So how do we differentiate? HAM is one of the signs. So if you see HAM in a patient with cystic fibrosis, it means it is ABPA. Apart from that, we cannot make the diagnosis basis the HRCT findings. It needs the immunological picture, the presence of serum eosinophilia, and the other allergic test, etc., need to be kept in mind. So the take-home messages are that ABPA can present with central as well as peripheral bronchiectasis. Sensitivity of central bronchiectasis as a predictor for ABPA is rather poor. We should not be relying on it alone. HAM is pathognomonic and should be actively sought, but it is seen in only 20% of the patients with ABPA. And HRCT can be normal in almost 1/3 of the patients with ABPA. So, thank you.
Manoj sir, you're on mute. Yeah.
Thank you, Dr. Khushbu, for comprehensive review of radiological findings in ABP and its clinical correlation. And as expected, this is the best radiological review of ABPA that I've ever heard. Thank you so much. And I hope you're continuing to be on the panel, or you're going to leave. What is your plan?
Sir, I will be leaving. In case you need me, if you can just ping me on phone, I will be around, sir. I had to meet someone.
Okay, so anyways, thank you so much. And it's very nice and kind of you to be there on board.
It's completely my pleasure, sir. And my miss to not to be on the panel today.
Thank you. Thank you. Thank you.
Thank
Looking
you.
forward to seeing you again. Thanks. Thanks a lot. Thank you. And I would request Dr. Nagaranjan to present diagnosis and treatment of ABPA. Doctor.
Yeah. Thank you so much, sir. So can you see my slides?
Yes, yes.
Yeah, and I hope I'm audible. So at the outset, I would like to thank the team ICS, especially Amita madam, for choosing this topic and choosing me for this topic. So 20 minutes is what I have to cover on diagnosis and treatment, which I feel is a gross injustice, but still I will try to do what best I can on the aspects of diagnosis and treatment. So this has already been spoken. So this is something which we have to understand, that here you have two components. You have fungus, you have Aspergillus fumigatus, and you have immunological response. So this is the basic thing on which the diagnosis and treatment is upon. So you have a fungus which is residing in the airways, colonizing the airways, and a subset of people who are predisposed to will develop an immunological response to this fungus within the airways. And this immunological response leads to the end result, that is the bronchiectasis and mucus plugging. So why so much of interest in ABPA? For three facts. One is that it can be the cause for the poor control of asthma. In fact, in all patients with uncontrolled asthma, we should make it a point that we have to screen for ABPA. Second important reason, as has been beautifully shown in the previous case, is that it is a preventable cause of bronchiectasis. So if you can identify and treat it appropriately, you can prevent end-stage bronchiectasis. Three is that it is a common disease, though it is still underdiagnosed. So most of us feel that ABPA is not there everywhere, but it is wrong. It is there all over the country. Aspergillus is a ubiquitous fungus, and it is there in every nook and corner of our country. It is just that we have to screen, and we'll pick up lots and lots of ABPA. And lastly, that it is a disease for which we have treatment, and treatment actually improves the outcomes. So this is the reason why it is important for us to learn about ABPA, how to diagnose. Recently, we have completed this multi-centric data ABPA registry. A lot of centers across the country have contributed. Hopefully, the results will be out in this year. Now, starting on with the diagnosis of ABPA, as has already been elucidated by Dr. Khushbu madam, it's a combination of clinical, immunological, and radiological. All three have to be pictured in. Now, clinical, is there, the most common presentation is that of an uncontrolled asthma. This is the most common thing. However, there can be certain rare presentations, as Dr. Manoj sir has rightly said, ABPA can happen without asthma also, but that is a very, very small subset. Usually it happens in asthmatics or in other predisposing conditions like cystic fibrosis. In India, it's many, many times mistaken to be tuberculosis because of the fact that it causes fleeting opacities. It sometimes can have fever. And when an asthmatic has hemoptysis, that is another time when we have to think about ABPA. Also, the third important thing is that not all ABPA presents as severe asthma. The more we screen, the more we realize that a subset of ABPA can be asymptomatic. A subset of ABPA can be well controlled. So this is about, it is all to do with how aggressively you start screening patients in asthma for ABPA. This is our own data. This is little old data where we had screened consecutive patients, around 120 asthmatics without any bias. And what we had found is that 27% were sensitized and 17% had ABPA. This is continuous. And the other important thing is that around 20% of these patients whom we eventually diagnosed ABPA were actually well-controlled asthma. Though a majority are poorly controlled, but a subset of ABPA can actually be well-controlled also. Now, coming on to the diagnostic tests, ABPA is one disease where India leads the research in the globe. And a lot of papers from Dr. Ritesh and team from PGI, I'll be quoting a lot of them. So these are all the tests which are commonly done to screen and to diagnose ABPA. Now we have to understand these tests. So what are these tests? One is the Aspergillus fumigatus skin test, Aspergillus fumigatus specific IgE, specific IgG, eosinophil count, and total IgE. CT and X-ray have been dealt. Now, sensitivity and specificity, if you can see, the highest sensitivity for picking up ABPA is for specific IgE, 98.2%, and total IgE level, that is more than 500, is 97%. So if you have to choose a single test for screening, then that would be either Aspergillus fumigatus specific IgE or a serum total IgE. So this is the first thing. So whom to screen? Ideally, though experts say that every asthmatic has to be screened, it may not be practical. So the more practical thing is that every uncontrolled asthmatic has to be screened. That is there. So if you can screen every asthmatic, nothing like that. Now, how to screen? Which test to use is, I would say, depending based on this study, you can either choose specific IgE or total IgE as a screening tool. Now, each of these tests, so Aspergillus fumigatus specific IgE, as I have said, this is the most sensitive investigation. The cutoff is not 0.1. The labs give 0.1 as the cutoff. We should remember that it is 0.35. It's 0.35 KUA per liter. Nearly 100% sensitivity, but specificity is not 100%. And the guidelines now recommend this as the most preferred screening test for ABPA. Serum total IgE is a very, very useful test, both for diagnosis and for monitoring. It's important to remember that specific IgE cannot be used for monitoring. It's only used for diagnosis. Whereas total IgE is important for monitoring because the levels go up and down. And based on this total IgE level only, you define remission and exacerbation again. So this is very important. Now, what is the optimal cutoff? Earlier, 1000 was the cutoff, 1000 IU per ml. But the study has shown that if you use a cutoff of 500, you will actually improve sensitivity by 8% by not losing specificity. So now the recent guidelines now say that 500 IU per ml should be the cutoff for diagnosing ABPA and not the earlier 1000 units per ml. Now the other thing, the new thing is the recombinant antigens. The earlier Aspergillus fumigatus specific IgA and IgG use a crude antigen. So there is some overlap with other fungi. Now, if you use this recombinant Aspergillus fumigatus antigens, that is F1, F2, and F4. So there are actually F1 to F6. Earlier, these were not commercially available, but now some labs are actually offering them commercially also. They have a very high specificity for diagnosing ABPA and differentiating SAFS from ABPA. But however, I would like to reiterate that this has not yet been incorporated in the diagnostic algorithm. CT, I would not talk because it has been covered. Now that you understood the tests for diagnosing ABPA, now how to incorporate them to form a diagnostic criteria. So as has been elucidated by the previous speaker also, the original criteria were the Rosenberg-Peterson criteria. Then in 2013 came the Isham criteria. So since then, Isham criteria were one of the most commonly used criteria for diagnosing ABPA. This was the original Isham criteria where you have to have a predisposing condition. So this can be asthma or cystic fibrosis. In India, it is asthma. Recently, a group of experts again met this ISHAM. So in 2024, we're going to have the ISHAM next version, second version of ISHAM. And I was lucky enough to be a part of this new ISHAM group, which will be updating the guidelines which were published 10 years before. So in this new ISHAM, we have included COPD also as a predisposing condition. Then you should have an obligatory criteria, which means that both have to be there. So what should be there? You should prove that there is sensitization to Aspergillus fumigatus. Earlier, both skin test and specific IgE were considered to be representative. But now skin test has been shown to be much less sensitive than specific IgE. So now specific IgE is the test which is being recommended. Plus, you should have elevated IgE. In 2013, it was 1000 as the cutoff, but the new ISHAM criteria is recommending 500 as the cutoff. So you should have a predisposing condition. You should have both the obligatory criteria and then the minor criteria. You should have 2 of the 3. So what are the 3 minor criteria? One is eosinophilia, either present or past, of more than 500 cells per microliter. You should have radiological opacities consistent with ABPA, which have been described by Dr. Khushbu Madam. And you should have either precipitating antigens or specific IgG in the serum. So this is the 3 criteria, of which 2 have to be there. So this is a summary of all the criteria proposed. A little congested slide, but I'll just quickly go through. The RP criteria were the original ones, which we won't be talking about. Then came the ISHAM. Then the modified ISHAM published in 2021. In 2024, we will have the ISHAM updated guidelines. So the difference between the ISHAM and the modified is 2. One is the cutoff for IgE. It has been brought down from 1000 to 500. Second is the skin test has been removed. And now it is only specific IgE. And serum precipitants have been removed and it is now only specific IgG. The cutoff for specific IgG is 27 milligram MGA per liter. Then there is another group from Japan, which is also very, very active on ABPA. That is the Asano criteria, where they give a lot of importance on bronchoscopy and mucus plugs. If you can see, they have classified ABPA based upon the presence or absence of mucus plugs, because they feel that makes a lot of difference on the prognosis. Now, the diagnostic algorithm. So whenever you have a person with risk factors or a compatible clinical presentation, you should do a screening test. So the guideline says specific IgE, but if you don't have specific IgE, at least you can use total IgE. If that is positive, then you do the other tests. So if specific IgE is elevated more than 0.35, total IgE is more than 500, then you have to look for the 3 minor criteria. And if 2 are there, it will be called as ABPA. But if IgE's level is less than 500, but specific IgE is high, it will be called as Aspergillus sensitized or SAFS, severe asthma with fungal sensitization. This is a very brief diagnostic algorithm for ABPA. Now, treatment of ABPA. So this is about diagnosis. So in the next 10 minutes, I'll talk about treatment of ABPA. So as I have said in my first slide, what is there? ABPA is basically fungus in the airway, immunological response to the fungus. So how do you treat it? You either block the immunological response or you remove the fungus. So you either can use anti-inflammatory therapy, that is steroids or monoclonal antibodies, or you can use antifungals. So this is the basis on which the drugs are being tested or used. So from ages, steroids have been the mainstay for management of ABPA. Now I'll be talking about 3 randomized control trials, all of them published from India, all of them published from PGI, which have changed our approach to managing ABPA. So all of these are patients of acute ABPA, newly diagnosed ABPA. So this is the first study published in 2016. This is an RCT comparing high and low dose, medium dose glucocorticoids. Earlier, higher doses, that is around 0.75 to 1 milligram per kg of glucocorticoids or prednisolone equivalent was being given. But this was compared with the medium dose, that is 0.5 milligram per kg. And what they have shown is that the response rates are similar and the time to first exacerbation after remission is also similar between medium dose and high dose. So with this, what happened is people started to use medium dose for managing patients of ABPA. Then the second RCT was published in 2018, that is comparing itraconazole monotherapy with oral corticosteroid monotherapy in acute ABPA. Again, if you can see here, this is the prednisolone group, itraconazole group 63 and 68. At the end of 3 months of therapy, both groups had 100% response. So itraconazole was working as good as prednisolone in inducing a remission in patients with ABPA. Then sustained remission. So after stopping treatment, how many people were relapsing? Again, this was almost similar between the two groups. So with this, they have proposed that itraconazole is probably an effective alternative to steroids for managing patients of acute ABPA. The third study is on voriconazole. So there are certain problems with itraconazole. The fact that it has differing bioavailability and differing absorptions, so the drug levels may not be achieved in all. So voriconazole was tested with prednisolone in acute ABPA. Again, here they have looked at composite response. Again, you can see by the end of 3 months, 196%, all of them were achieving remission. And then the number of people exacerbating after stopping therapy at 1 year and 2 years, almost similar between the two groups. So again, voriconazole and prednisolone were faring equally well while treating acute ABPA. The last thing is the combination, whether combining steroids plus antifungal is better than steroids alone in managing patients of acute ABPA. So this study, they have not looked at the remission rates because we already have seen that even monotherapy with prednisolone or monotherapy with antifungals can induce 100% remission. So the outcome here was exacerbations after stopping, that is the relapses. So what they have shown is the number of people relapsing in 1 year is 33% in OCS and 20% in the combination. So there is, though the numerical decrease with the combination, this is not statistically significant. But in certain subgroups of people, like people with extensive bronchiectasis more than 10 segments, very high eosinophils more than 1,000, or recurrent exacerbations more than 2 per year, this combination was probably superior to OCS monotherapy. However, this has not yet been incorporated in the current treatment guidelines, but this is something which can guide us in deciding in whom way we want to use upfront combination of prednisolone and itraconazole. So this is to summarize ABPA therapy. So since ages, glucocorticoids have remained the backbone or the cornerstone for managing ABPA, but the dose at which we use has come down to medium dose, that is 0.5 milligram per kg to begin with, and then slowly we taper down, and then we give for 4 months and then stop. Now there is data to say that where people cannot tolerate steroids or don't want to take steroids, monotherapy with antifungals, itraconazole or voriconazole, can be a reasonable first-line alternative. And OCS plus antifungal combination can be considered in people who are a high risk of exacerbations. As I have said, extensive bronchiectasis, high eosinophil counts, or a fungal ball, an upfront combination therapy may be attempted. Now there is a lot of interest in nebulized or inhaled antifungals, whether they can be used to decrease relapses. As Dr. Manoj sir has rightly said in the beginning, that this is a disease where we can achieve 100% remission, but the problem is exacerbations, relapses. So now what can we do to prevent further relapses is people have tried nebulized amphotericin B, both conventional and liposomal. These are the two studies which have been done, the Nebulamp and the study from India. Varying results, but then probably in the upcoming years, we'll have more data and we might start using these nebulized amphotericin B to prevent relapses. This is still in the nascent phase, not yet approved for regular use. Newer azoles, again, we don't have much data. Then I would like to talk about biologics in ABPA. I'm sure that most of us are off-label using these for patients of steroid-dependent ABPA or frequently relapsing ABPA. So many biologics have been tried. In fact, now there is an RCT going on of mepolizumab in ABPA, on benralizumab in ABPA. So because ABPA is characterized by high eosinophils and high IgE, logically, anti-IgE and anti-eosinophilic agents all can work. So all of these have been tested in case series and case reports. We also have been using it for the last couple of years with good results. But again, if you have to talk about guidelines, there is only a mention about this in the guidelines, but they're not officially used. This is about biologics. So with this, I'd like to come to my take-home messages. So it's very important to always suspect ABPA. Ideal is to screen every asthmatic If it is not possible, screen all uncontrolled asthmatics for ABPA. Screening test for ABPA is Aspergillus fumigatus specific IgE. If you don't have it, you can use serum total IgE as a screening test. The earlier you diagnose, the better it is, because you can halt the progression of ABPA. Then glucocorticoids are the treatment of choice, but now triazoles are a good alternative agent. Treatment is associated with good outcomes, but the problem is relapses. However, a lot of research is still being done, and I'm very sure in the next couple of years, we'll have more data which can further give us answers. I think with this, I would like to thank, and I will again hand over to Manoj sir for the panel discussion and any questions, if any.
Thank you, Dr. Nagarajuna. And in 20 minutes time, you've done an excellent job, actually. And listening to your talk, it looks that we are going to have an exciting time with ABPA management. We are going to have new diagnostic criteria, and possibly there's going to be a paradigm change in the management of ABPA. But today we are discussing what is the standard of care today. And because we have to go according to guidelines, of course, we can have the off-label use of various modalities, various treatments, and we do use them. But the idea today is to discuss what is existing recommendation and how we should be treating ABPA as of now today. So thank you once again to you for such a elaborate discussion on diagnosis and management. In fact, it has covered most of the aspects of the panel discussion that we have, but still there's a lot that we need to discuss and understand more about ABPA. So as you know, we have discussed that the diagnosis ABPA is basically a constellation of clinical presentation, radiological findings, and immunological tests. The clinical presentation would be non-specific. You can have this kind of presentation, tuberculosis, in other conditions as well. The radiological findings may not be there. You may have a normal CT scan or a chest X-ray in a patient with ABPA. So if you look at the overall scenario, the diagnosis of the ABPA is primarily immunological. It's based on the immunological test or the serological test. So my first question goes to Dr. Shivani. Which is the most sensitive investigation for the diagnosis and screening for ABPA? Which test you prefer outright for the screening of ABPA? Dr. Shivani, please.
So thank you for the question. So I think, like Dr. Nagarjuna has already mentioned in his talk, that the most sensitive test is actually the IgE, which is specific for Aspergillus, which has a high sensitivity of around high sensitivity and specificity. And however, when we are seeing patients in OPD, like Dr. Nagarjuna has also said, that the next best test that we can do is the total IgE, which also has a sensitivity of over 97%. So that is also the other test that we can use in the OPD patients.
Yeah, so that's absolutely right. So we understand that Aspergillus specific IgE is the most sensitive test for screening. But this cannot be used for the follow-up of the patient, because IgE levels may increase despite the patient going to the remission. And similarly, the IgE levels may not go up in patients who are experiencing the exacerbation. So very well said, Dr. Shivani. Now, coming to the other aspect, we talked about the skin prick tests, and the skin prick tests are actually analogous to the presence of raised Aspergillus IgE levels. But Dr. Parames, do you practice the Aspergillus skin prick test? And if not, why the skin test is currently not preferred or favored test for the screening of asthmatic patients for ABPA?
Thank you, sir, once again. And yes, in the inhalation panel, we do have this Aspergillus skin prick test as well. But as Dr. Matru mentioned, in the newer criteria, the Aspergillus specific skin prick test is basically out of the criteria, because basically of few reasons. Because the patients, from his initial chart itself, you could see that the sensitivity and the specificity both are not highest with this thing. So you are bound to miss this thing. Miss the ABPA in about 25 to 30% of the patients who are having actual ABPA. as per the clinical guidelines, the flow chart. So that is one thing. And also we have got enough problems in doing SPTs for practical problems, not the scientific reasons that I am mentioning, practical problems in checking the patients may be having receiving medicines like antihistamines, and all the patients may not get positive skin prick test as well. And also it's an observer dependent test also. So absolute criteria may not be extrapolated in each and every patient. So I usually don't prefer Aspergillus specific skin prick test for screening ABPA, but rather use IgE and Aspergillus specific IgE along with other clinical and the radiological criteria. Thank you.
Thank you, Dr. Parmez, and this is very well said. Another risk with the skin prick test is the theoretical risk of anaphylaxis. So it has to be done only in conditions where you can be able to manage those anaphylactic reactions. So that is one thing. And as Dr. Mataru said, that the skin prick test is going to be out of the diagnostic algorithm of ABPA in the future. Now, my next question would go to Dr. Kamlesh Pandey, and we all discussed that IgE is another useful test for the diagnosis and follow-up of the patient with ABPA. And normal serum total IgE nearly excludes the active ABPA in a patient. And this test is widely available and can be done in every nook and corner of the country. The sensitivity of IgE cutoff, as Dr. Matru said, with 500 is very high, maybe close to 98%. But problem with total IgE is that its specificity score is around 24%, and therefore it is not a good test for the screening for ABPA. But it's a good test for follow-up of the patients. So my question goes to Dr. Kamlesh, and I would like to ask him, do you think that serum total IgE is the best immunological test for the follow-up of these patients? And how do you use serum total IgE for the monitoring of these patients?
Yes, sir. Yes, as you rightly said, that it's a very sensitive test, but not specific. So during the follow-up, if the levels of IgE are declining along with clinical and radiological improvement, then it suggests that it is a good, the patient is showing good therapeutic response to the current treatment. So the declining level helps us in understanding that patient is responding. Whereas if the levels of IgE is increased along with clinical deterioration, it suggests that patient may land up with exacerbation or is exacerbating. In different trials also, a declining level of IgE levels of more than 25 to 35% suggests a very good response to treatment. And a declining level can give us confidence that we can taper out the steroids since the IgE is declining and patient is also getting better clinically and radiologically. And also one more thing, in a patient with well-controlled ABPA, a normal level of IgE does suggest that the cause of if patient is symptomatic, the cause of patient symptom could be something else rather than active ABPA. So it's a very useful test for monitoring the disease.
So that's absolutely well said. And actually, when you're treating these patients, you're trying to achieve, a level which is 25% lesser than the baseline level and maybe better than that. But you're not trying to normalize the IgE level and continue these patients with the therapy. So that is one very important aspect. And then you are always trying to guess what is going to be the new baseline of these patients. So once you achieve this new baseline IgE level by doing a repeated test over a period of time, then if the patient exacerbates, then you find that this goes up by 50% from that new baseline, then you know this patient is exacerbating in presence of other clinical and radiological criteria. So this is very well said, Dr. Kamlesh. Thank you very much.
Can I just add one thing? I think the one point which I had said rightly, that we should tell all our patients also that we don't expect normalization of IgE levels, because many times patients are very actively looking at their IgE levels, that it will drop by only 25% or 50%, but it will still remain high. I think this is something which we should probably tell all our patients before itself.
Sure.
Yes. So we also learned, during your presentation, Dr. Mataru, about the severe asthma with fungal sensitization, and these are the cases who have got raised Aspergillus specific IgE level, but the low total IgE level. So my question goes to Dr. Barnali Datta, madam. How do you watch out for ABPA in these patients? Because many of these patients would later develop ABPA. So I'm asking this question from the diagnosis point of view, ABPA in these patients, rather than the treatment point of view. Dr. Bernali, madam.
Ma'am, can you please unmute yourself?
Sorry, yeah, unmuted. So I think it's very important to understand that this interplay of the fungus with the airway, it is a whole spectrum of disease. So none of them kind of exist in isolation, and it begins with simple fungal sensitization on one end, and on the other end, we have structural lung damage with extensive bronchiectasis, and everything is kind of in between. So fungal sensitization is when we see that, yes, Aspergillus specific IgE is raised and total IgE is moderately raised, not terribly raised like we see in ABPA. And those patients sometimes may have, in simply sensitization, they may have very controlled asthma. They may not have any symptoms, significant symptoms at all. And then it goes on to SAFS, where you have severe asthma. And again, the immunological criteria go on to serological ABPA, and then finally ABPA with structural changes, bronchiectasis and mucus plugging and things like that. So I think it is important to know the serological testing, like you said, for diagnosis. When we go to the ABPA domain, then of course we have to look at not just the total IgE and Aspergillus specific IgE, but also the eosinophil count, the radiology, and the clinical symptomatology. All ABPA may not have severe asthma, but SAFS definitely, the asthma is very severe, and there is fungal sensitization alongside. So it kind of exists as a spectrum from simple sensitization to structural lung damage, and it is very important for us to recognize these entities, because all of them, then only can we treat them appropriately, and the prognosis also differs depending on what level of involvement there is, serologically and clinically, radiologically, etc.
Yeah,
I hope that answers the...
So, we really have to watch out and keep a close eye on these patients, because 40% of these patients can later develop the allergic bronchopulmonary aspergillosis. So, repeated, serum Ig level or Aspergillus Ig level must be done in these patients, maybe every year. And as and when you suspect, some activity is going on or asthma exacerbation is going on, then you must repeat the ABPA panel in these patients, definitely. Thank you, Dr. Pranali. Now, my question goes to Dr. Nagarjuna. Again, the blood eosinophil count is a very important criteria for the diagnosis of ABPA, and now we know the cutoff is more than 400. So my question is, do we accept that the peripheral blood eosinophil count of more than 500 is a good cutoff for diagnosis of the ABPA? And other question is, do we have an over-reliance on eosinophil count for the diagnosis of ABPA in India?
Sir, I think the first thing we have to realize is that it is not in the major criteria, because there are several reasons for elevated eosinophil count other than ABPA, and the normal eosinophilic phenotype asthma itself will have an elevated eosinophil count. So that is the reason that eosinophil count is not the primary investigative tool for diagnosing or screening ABPA. The cutoff which has been used in the guidelines is 500. I think that's okay, but it is only after you prove sensitization, after you prove elevated IgE, only then you look at eosinophils. So I think so eosinophils count come lower in the algorithm, not higher in the algorithm when you try to look at ABPA. There's so many other reasons for eosinophilia.
That's all right. So sometimes, you have various criteria, but the eosinophil count is low, and they're not, 500, maybe 200, maybe 100. But, this may not deter you in making a diagnosis of allergic bronchopulmonary aspergillosis, because there could be many causes of low. You have talked about the high eosinophil count, but there are many causes of low eosinophil count also. These patients may be on oral corticosteroid for some time, maybe on high dose inhaled corticosteroid, which may bring down the eosinophilic counts. So again, my point is, if there is over reliance on the, cutoff of the eosinophil count, the absolute eosinophil count, then we may be missing few cases of ABPA. I hope you agree with me, Dr. Nagarjuna. You want to
100%? No, 100% yes, sir. So it is always the whole thing, whole picture together. So if every other criteria is satisfied, even if you don't have high eosinophil counts, you are justified in labeling it as ABPA. Correct.
Thank you very much. And I think this is a very important message, because especially the students, they have been fed like this, that, eosinophil count has to be more than 500, otherwise it cannot be ABPA. So that is something that, we have to remember, that you can make a diagnosis in appropriate conditions, even though the eosinophil count may not be reaching the cutoff. So my next question goes to Dr. Shivani Swami. The chest X-ray is innocuous, initial, very cheap or economical test. What is the importance of chest X-ray in the diagnosis of ABPA and follow-up?
Sir, I think the first thing that we need to understand when we're looking at the X-ray of a patient in OPD is that there are going to be transient changes in the X-ray and there are going to be permanent changes in the X-ray when we're looking at a patient with ABPA. So the transient changes are something that, with time may go, which commonly that we see are, of course, the patchy areas of consolidation or infiltrates, the patchy infiltrates which come and go. So they may be present, they might migrate to another area subsequently in the follow-up X-rays. Also, there can be segmental or lobar collapse, which may or may not be present, which are transient in nature. And very rarely, of course, like Dr. Khushbu has already elaborated, that there may be, pneumothorax, pleural effusions, other tram-like shadows. Also, I forgot that the permanent, when we're talking about transient shadows, the finger in glove shadows that Dr. Khushbu had showed a beautiful X-ray of is also one of the very key features. And when we are looking at permanent shadows, there could be, there could be fibrosis that can be seen eventually. Of course, central bronchiectasis is also something. But the pathognomic, like Dr. Khushbu said, is something on the CT, which is the high attenuation mucus, which is seen, and is very important that even on subsequent radiology, that is something that we follow up to look for response in these patients.
So that's absolutely right. So chest X-ray plays a very important role in the management of ABPA. But initially, it may be missing the subtle signs of, bronchiectasis and the minimal signs of ABPA. And therefore, initially, a CT scan possibly is must if the chest X-ray is normal. Normal chest X-ray does not rule out the possibility of any radiological involvement in ABPA. Therefore, initially, at least, we must do a CT scan. But yes, if there are gross abnormalities, and especially for the follow-up, the chest X-ray would be very useful. And those fleeting, pneumonitis patches, which is so classical of, ABPA, would also be seen. So chest X-ray would be very important in follow-up of the patients of, ABPA, because you can't do a CT scan every day or every month. So that is important. Thank you, Dr. Shivani, for such nice comments. And then coming to Dr. Parames, we have already talked about this, but I would like to know about from you, which you think is the most pathognomonic radiological finding in ABPA?
Pathognomonic finding, especially as far as the CT is concerned, is already mentioned by multiple speakers and the panelist, Dr. Shivani. It's a HIM finding. It has got very good specificity, radiological specificity, as far as when you see that the radiologist or the pulmonologist are in line with the diagnosis of ABPA mostly, or at least ABPM should be suspected. But as Madam mentioned, it happens only in 25 to means maybe at the most 25% percentage of individuals. So high attenuated mucus is definitely the pathognomonic feature that you can, if you want to see a single entity in the radiology, HIM may be the pathognomonic feature.
Yes, I totally agree with you. But unfortunately, I don't know about the other panelists, but over the last 30 years of my career and, after doing post-graduation, I have hardly found a CT report reporting the HAM, the high attenuation mucus. I don't know, the radiologists possibly are not looking into it or they are not seeing it, but I don't see this kind of report from the radiologist, even though, it's a very, very important pathognomic criteria. What do you think about that, Dr. Parames?
Probably we need to have more conversations and the CMEs, the interdepartmental meetings and all. That might be the reason that you may not be seeing that. But of late in our hospital, it's been started mentioning in the CT report. Probably it was not it is a recent as compared to a previous lung finding or the radiological findings or pathognomonic findings, it has come up recently, maybe a decade or a half, and probably that is the reason there may be much more hesitancy in this thing. And there was also confusion when I was going through the journals and all those things. Dr. Agarwal had mentioned in the chest journal about one a letter to the editor about an article where the ham has been mentioned erroneously in that particular article, where you mentioned ham when your attenuation is more than that of water. And he has actually corrected that into it should be, as Madam mentioned, it should be more attenuation than that of the paraspinal muscles. So these things may be the factors which may be hindering this reporting system, is what I believe.
Dr. Mataru, would like to add on to this, why a ham is not so commonly reported?
Sir, I think the importance of ham is probably not appreciated by the radiologists. That is all I will tell, because they have seen so many films where ham is there, but the report doesn't say it as ham. They report mucus plugs. Mucus plugs are always reported, but ham is not reported. It is, I think, as Dr. Parmeshwar has rightly said, it's a combined meeting with the pulmonologists and radiologists. I think that should solve the problem.
Thank you. Thank you. I think that's very nice. And I think the time has come that we, advertise more about ham and sensitize the radiologists about its importance. And they ask them to, watch out for it and look for, this finding. Because once ham is reported, then, you're absolutely okay with that. The problem is, when this in-house CT scan, you can, find it out and see it. But when your patient comes to you from outside, has just got the films, and there, this ham may not be visible. And we then have to depend upon the radiologist report. So that's very important. The time has come that radiologists should get used to it, and we must help them out, in looking for the ham signs in their pictures. So now, next question again comes to Dr. Kamlesh Pandey, and my question goes to you is about the role of sputum culture and galactomani in the diagnosis of ABPA.
Yeah. So again, sputum culture positive for aspergillus fumigatus will not be very diagnostic, because this fungus is ubiquitous. And so it will not be diagnostic. But since ABPA patients many times have bronchiectasis, the role of sputum culture becomes very important to understand whether there is any other fungi or whether there is any other bacteria like Pseudomonas which has colonized. And further, the DST on the culture would guide us to give appropriate antibiotics. Another very important factor for sputum is sputum for TB culture, because many times these patients are on steroids and they can land up with tuberculosis. So sputum TB culture also would be very important. Regarding galactomannan, again, it is very sensitive and specific for invasive pulmonary aspergillosis, but has poor sensitivity and specificity for ABPA.
Very well said. And, sputum culture was actually initiated in the Rosenberg-Peterson criteria early, and now the Isham criteria do not talk about it. But as you said, sputum culture is not only for fungal infection, but also for microbiological point of view. Other microbiological point of view is very important, especially tuberculosis, and for Pseudomonas colonization, because that is likely to change our management in these patients. So that's very well said. And as you said, serum galactomannan and bile fluid galactan all have a very poor sensitivity, and therefore is not the test recommended for the diagnosis of ABPA. Now, coming to Dr. Bernali Datta, madam. Ma'am, the Rosenberg-Peterson criteria have been there for ages. And, we as, clinicians have followed these criteria over a period of time. And then came the Isham criteria. So what do you think about the limitations of Rosenberg-Peterson criteria?
Yeah, no, absolutely. So we followed, these criteria was all that was available to us for, a great many years. And I think some of the problems it ran into is that it had a whole host of primary or major criteria, 7 and then 3 minor criteria. But there was never a consensus on what is the number of components in these criteria that have to actually be positive to make a diagnosis. And that was always very loose. And, often you'd see a patient that you knew in OPD had ABPA, but, how many criteria actually did you have to meet before you could label it? So that was certainly one of the things.
Hello?
Second thing is, as you also pointed out, the cutoff values. The cutoff values, I think, is an important thing, because to say greater than 1,000, you have a patient, definite ABPA, but the greater than 1,000 is not always the case. And you will still label it ABPA because the other criteria are fitted in. But to have an absolute value sometimes is perhaps not so helpful for clinicians, because that you see a whole spectrum of values when you see it in real life. And that was again pointed out by Dr. Nagarjuna, that now that has been brought down in more recent ISHM criteria to 500, and that is probably much more realistic. And then standardized methodologies for these immunologic tests. And so a few of these factors, I think, came together, and researchers and clinicians, they were using the criteria variably. And perhaps rightly, we needed something that was more defined and more streamlined. And I think that's when we went on to the ISHM criteria, which is actually you can apply it very easily sitting in OPD. And you don't need to go through the list of, 7 to 10 criteria, which you don't know, how many of them have to be positive. So I think it is something like that we had to move on from that. And again, the importance to IgE total and Aspergillus specific IgE is, that should be given more weightage compared to some of the other things, so that I think has been addressed very adequately in the newer guidelines that have come out.
Thank you so much, and for such elaborate explanation of how Rosenberg criteria, Pettis criteria are no more useful. And I would like to have final comment on this from Dr. Nagarjuna. Do you think we should say goodbye to Rosenberg-Patterson criteria for now?
Sir, I think we've already said it.
Yeah.
So nowadays, nobody uses the RP criteria. It is always the sham criteria, except the Japanese group, as I've said, the Asano, they have a different thinking where they use their own criteria. But other than the Japanese, I think the world over, they follow the sham criteria for diagnosing ABPA as of today.
And world is grateful to you, Dr. Ritesh Agrawal and Dr.
Correct. Yes. I think this is in asthma. I think if it comes to CF and other diseases, it is slightly different. But when it comes to ABP and asthma, I think the ISHM criteria is what is being followed globally.
Yes, so I think the world is grateful to you, Dr. Ritesh, and Dr. Great Dr. Guleria, for giving these criteria to us. And really, it has simplified the classification and diagnosis and management. Very crisp criteria, very authentic looking criteria, as a matter of fact. And now we are going to have new criteria as well in the coming days. So I think we are going to have paradigm shift in the diagnosis and management of ABPA. Now, my next question again goes to you, Dr. Nagarjuna. What is the importance of radiological classification of ABPA? How does it help in managing these cases?
Yes, sir. So first, I would like to say about the radiological classification, a slight change from what Dr. Kushbu Madam has said. So earlier, the ISHM has said there are 4 categories: ABPA S, where there is no bronchiectasis; ABPA B, earlier it was called ABPA CB, where central bronchiectasis, but now it has been shown that a significant subset of them have peripheral bronchiectasis, not necessarily central. So the word CB has been changed to B. So it's called ABPA B. Then third is ABPA B with HAM. And the last thing was ABPA other radiological findings. So what is the implication? There are 2 things. One is the prognostic implication. Second is therapeutic implication. So definitely prognostic implication is there, which was told by Kushbu Madam also, that HAM implies immunologically more severe ABPA, as evidenced by higher eosinophils, higher IgE levels, and a higher recurrence, higher relapse rates. So definitely, if you have ABPA HAM or now ABPA mucus plugs also, any mucus plug, not necessarily a high density mucus plugs, the presence of mucus plugs itself says that it is an immunologically more severe disease. So yes, it has a prognostic value, but does it have any therapeutic significance? is something which, as of today, the guidelines do not say that you treat ABPA-S or ABPA-B differently. So if it is a symptomatic person, either ABPA-S or ABPA-B, you would treat it similarly. So as of now, the guidelines do not separate these various radiological subgroups of ABPA, but this is a research question. So do we have to treat them separately? I'm very sure in the future publications, people are going to try to see whether each of them needs to be treated differently.
Do you think there could be a role of doing bronchoscopic aspiration? These patients, they got a ham or mucus plugs there.
Correct. I think in the chat box also, of all the questions which have popped up, there are two questions as to the role of bronchoscopy. One is when you have a mucus plug, do we have to remove them? The answer is no. If you have a segmental collapse, if you treat it with steroids, it is going to melt away. But there will be instances where you have lobar collapse leading to respiratory failure or hypoxemia, wherein you might want to initially remove the mucus plug so that the person improves. So that is a very, very small subset of people where you might want to do a therapeutic thing. Second is when you want to rule out infections. Suppose you are confused whether there is a secondary infection or an ABP or ABPA exacerbations. Sometimes you might want to do a BAL to rule out other infections. But therapeutic mucus plug removal for all patients of ABPA is not indicated because they respond to steroids.
So the current understanding is that, if you've given a steroid for about 4 weeks and still, the collapse of the segment, collapse consolidation of the segment or a low persist, then possibly we'll go in and do a bronchoscopy and remove those plugs. What do you
I agree, sir. If it is not responding, then you are justified in trying to open up the airway. But most of the segmental collapses, usually if you see in the follow-up, the mucus plug will go away and the dilated bronchus would usually remain. But if you have an instance where the mucus plug is refractory, not responding to steroids, definitely yes, you might want to do a therapeutic bronchoscopy in such a case. Yes.
So we have kept Dr. Shivani Swami away for quite some time. We bring her back. So we have already discussed at length the various diagnostic criteria and how we diagnose ABPA. So could you just stepwise give a diagnostic workup of ABPA? Just summarize how would you diagnose a case, Dr. Shivani?
Thank you, sir. And so I will refer back to a slide that Dr. Nagarjuna had presented about the diagnostic workup. When we look at an asthmatic patient, and for all practical purposes, an asthmatic patient who is very well compliant to the treatment, we have checked the inhaler technique and is taking his inhalers well and is still symptomatic or is still having frequent exacerbations. So this is this patient wherein we would like to work up and screen him for ABPA. So the first thing that we do is a IgE specific for Aspergillus, which if found to be more than 0.35, or else we can do a total IgE, like Dr. Nagarjuna said, over 500. So if this is the case, then we go ahead and do either a eosinophil count, which should be around 500, but then again is not very sensitive, or we do the IgG specific for Aspergillus, which is again a very specific test. It has a specificity of almost 100%. So when all these criteria are fulfilled and serological tests have been done, that, like you had correctly spotted, that then we move on to doing a HRCT, at least on the first visit, depending on which we can then categorize what radiological or whether serological Aspergillus ABPA is there in this patient, and then go on to treat that patient accordingly.
Thank you, Dr. Shivani. And I think with this, we have come to end about the discussion on diagnostic aspects of ABPA. Now we move on to the treatment part. So, Dr. Paramesh, we have as far as the management is concerned, the treatment of ABPA comprises of two tenets. One is the use of glucocorticoids as anti-inflammatory agents to suppress the immune hyperreactivity. And the other one is the use of antifungal agents to reduce the fungal burden in the airways. So my question to you, Dr. Paramesh, is to understand what are the goals of treatment of ABPA?
Yeah, the goals of treatment definitely has to be the patient's improvement in clinical symptoms and preservation of lung function. because we all know, as Madam Datta rightly mentioned, the spectrum with asthma with fungal sensitization to a stage where there is an irreversible damage of lung function. So the patients may present to you at any point of time, at any stage. So our target is to catch as early as possible in their illness and avoid as much as functional and structural change as far as the lungs are concerned, lungs and the airways are concerned. Because we all know that once the bronchiectasis sets in, there are a lot of other things that can complicate things, and patient may eventually go into respiratory failure and may end up in long-term oxygen therapy and or even surgical treatment part. So the goals of treatment definitely has to be preservation of lung function and also avoidance of frequent relapses. So both these drugs, as I mentioned in the original talk by Matru, has been effective when properly advocated and after thorough workup, will definitely help us in alleviating the exacerbations and also maintaining the remission. The major factor is that once the remission is achieved, we also have to inform the patient about the chances of relapses and proper follow-up. The proper checking of lung functions routinely has to be there, and also on a radiology assessment may be indicated if you are having a clinical suspicion of relapse. So, and as mentioned, the IG can also be, total IG can also be monitored to see if the patient is having any relapse or so. So in short, this is the way by which we may be managing the patient on a long-term basis, because you have got enough number of patients right now, because we have got a clarity by which in the last decade, we have got a clarity by which we can approach this case, this disease. And once the clarity is there, you are going to diagnose a number of patients. Then we have to have a certain set criteria by which we manage these patients and follow up these patients in a proper way so that the patients get enough benefit. Thank you.
Very well said, Dr. Paramesh. And just to summarize, the goals of treatment would include reduction of pulmonary inflammation, control of asthma, get the patient as less symptomatic as possible or make him as symptom-free as possible, treatment of acute symptoms of allergic bronchopulmonary aspergillosis, prevention of ABPA exacerbation once the patient has gone into remission, halt the onset of progression to bronchiectasis, which is very, very important. Otherwise, these patients may end up with chronic respiratory failure. And most important thing that you said was the environmental source control responsible for continuous exposure to aspergillus. So that is very important. It is not just treating the patient, but environment control is very, very important. Now, my next question goes to Dr. Barnali. Ma'am, we know as of now that steroids is the first line treatment of ABPA. In future, this guidance may change. But current standard practice is that the steroids are the first line treatment of ABPA. So how do you use a steroid in the initial management of ABPA, particularly in stage 1?
Yeah. Sure. Yeah. So I think it is very clear to us that steroids is the mainstay of treatment, because this is an immune response that we are trying to damp down. And I think Dr. Nagarjuna again had a slide on it, and that is the recommended way. We don't need high dose steroid. We just need a moderate dose steroid, which is 0.5 milligrams per kg, which is given for 2 weeks. And then the dose is halved for another 6 to 8 weeks. So after 8 weeks, it's important to assess where things stand. So if there is clinical improvement, radiological resolution, and the IgE as well has shown a reduction by 35%, then it is deemed fit to start tapering. And then the taper happens over a period of, say, 3 to 4 months at a pace of 5 mg per every 2 weeks, 2.5 mg per every 2 weeks. So I think that is what is in a kind of a prescriptive way it is given. But I think for all of us, that is what holds that we start at 0.5 mg per kg, and then 2 months we are, we have to keep at a certain level. And when we see response, which is defined as I said, then we start the taper, and a 6-month period is quite reasonable. And then, of course, the question arises that what then? And that is when it is so important to follow up the patient, because remission is again staying symptom free, with the IgE levels staying at the same level, well, at least less than what the baseline, the high levels had been, and clinical radiological stability. And if that is maintained without steroids for a subsequent 6 months, that is referred to as remission. But during monitoring, again, if there is an exacerbation, we may need to relook at the use of steroids. So I think that is where steroids fit into this. And of course, then there is the role of antifungals and other things, and basic control of asthma as well.
That's very rightly said, Bernali ma'am. Steroids are used in the acute management of ABPA stage 1 and also in first exacerbation. So up to first exacerbation, the steroid remain the mainstay of the treatment. And then you move on to the other modalities, whether you combine triazoles and other things. Now, standard, for one line, if I have to recommend, what would be the dose pattern of prednisolone in these patients? Of course, prednisolone is the one that we use most often. And that would be 0.5 milligram per kg for 4 weeks, then 0.25 milligram per kg for another 4 weeks, followed by 0.1255 milligram per kg for 4 weeks, and then taper by 5 milligram every week. And as Dr. Bernali said, that this is what not going to be the standard. We have to follow according to patients' clinical and radiological response. The timeline standard is 4 months, but this can vary. It can go up also. So that's very nicely covered and said. Now, coming to antifungals, and we know that antifungal agents act by reducing the fungal load, and thereby we minimize the potential for ongoing inflammatory activity. So lower the fungal load, lower with the inflammatory activity. That looks very mathematical. But still, the antifungals are not used as the initial therapy in ABPA. So my question goes to Dr. Kamlesh Pandey. When would you use antifungal therapy, itraconazole, and why the antifungal agents as of now are not considered as the initial therapy in ABPA? Dr.
Yes,
Kamlesh?
sir. Mainly for 2 reasons, as steroids have been very effective in decreasing the symptoms as well as controlling the symptoms as well as improvement. Hello? Am I audible, sir?
Yes, please. Yes, please go ahead.
Hello?
Yes, you are audible.
Sir, mainly the response to a period of time, and it works very well in acute ABPA. But Dr. Nagarjuna also showed that even antifungals upfront work equally well. But we are more comfortable with using as a first line of treatment, and also because of side effects of the azoles, the hepatotoxicity, the monitoring of LFTs, preference as a first line treatment for when I will use antifungals when the patient is on is not responding or partially responding with persistent radiological opacities. I would like to add on antifungal itraconazole 200 mg twice a day for 3 to 4 months. Second case, in patients whom I want to taper off steroids quickly, or those patients who are having comorbidities like diabetes, like osteoporosis or peptic ulcer, where I would like to reduce the steroid early, there I would use antifungals along with steroids. And once the patient is well controlled, then taper off. And third, in a patient who is already on corticosteroid and still having exacerbation, then I would like to add on itraconazole in these patients to achieve control.
Yes, so I think that's very well said. And itraconazole actually is introduced in the second exacerbation onwards. So the initial treatment, acute stage, and the first exacerbation, still go ahead with the corticosteroids and then itraconazole. And what about the other triazoles and the nebulized amphotericin B?
So other voriconazole studies have shown that voriconazole works equally well as itraconazole. And the newer molecules, still the data is missing, but over a period we'll get more data about the isavuconazole and posaconazole. And again, Dr. Matru showed already the liposomal amphotericin B, and the mechanism it will work, it will reduce the antigenic stimulus to the inflammation. And by reducing that, we may achieve decreased number of exacerbations and overall control of ABPA.
So as of now, itraconazole is used as a second-line treatment, but as we understand, ABPA is just not an allergic phenomena. It is actually interplay of the allergic phenomena, the hypersensitivity phenomena, and the infection both. And therefore, as the new guidelines are going to come up, possibly this line of management is going to change, and we may have to start, the antifungal treatment along with the steroid upfront in every case of, ABPA initially, and possibly that may reduce the overall outcome of these patients. And the remissions the exacerbation that we are facing to the tune of 50%, which is absolutely worrying, have to come down. And possibly, personally, I mean, this is my personal opinion, if we combine itraconazole upfront with corticosteroid, possibly we are going to reduce this inflammatory response much better and prevent the repeated exacerbation and prevention of bronchitis in these patients. So possibly this is what we're going to have by the end of this year. But as of now, the itraconazole remains the second-line treatment, and most of the time used in combination with the steroid, but sometimes alone when you're having the severe side effects of the glucocorticoids and when you feel the steroids are not working. Other point is, in my experience that I've seen, many times the dose of 200 milligram of itraconazole twice daily does not work. And if we're not doing any therapeutic monitoring, therapeutic drug monitoring, itraconazole is not available. So in those cases where patients who are not responding, as of now, initially or the combination of glucocorticoid and itraconazole, possibly increasing dose of itraconazole may work, or we may have to change to other azole, that is voriconazole and isavuconazole. But we would still prefer itraconazole because it is much more cheaper than the voriconazole and isavuconazole, and the treatment has to go on for at least 6 months. Anyways, so my next question goes to Dr. Nagarjan. How do you follow up these patients on treatment?
So this is a very important thing for the clinicians. What is the frequency at which we have to monitor and how do we follow? So as Dr. Banali Madam has rightly said, the first time at which we reassess the person is at the end of 6 to 8 weeks. So that is the timeline. Then how do we follow is you have to use a holistic tool. It's called a composite measure. You have to picture in clinical improvement. You have to picture in radiological improvement, and you also have to demonstrate immunological improvement. So clinical improvement is subjective. There is no objectification of how to say when the person has responded or not. It is the patient and the clinician who sit together and decide whether it has improved or not. Radiology also is to some extent subjective. What I would like to say is that when you talk about radiology, you're not talking about repeating a HRCT. You're redoing a chest X-ray. So only a person with an infiltrate on chest X-ray can be monitored radiologically. The most important thing is immunological response. This Dr. Manoj sir has already said in the previous answer that IgE is the thing which you have to use, not specific IgE, not specific IgG. And IgE level decreases by 25%, that is sufficient. It will not come to normal. So it will come down to a new baseline. That is called a new baseline. So a remission, a good response is defined as an immunological response plus clinical radiological response. So that is how we follow. And then once the person achieves so-called remission, it is important to realize that they are prone for relapses. So we have to prime the patient and then we have to keep monitoring them. Again, the optimal frequency at which we have to redo these tests is not tested scientifically. It is more eminence based, and people say every 2 to 3 months or when the person has clinical worsening.
That's absolutely all right. And I think if somebody is on itraconazole, again, monitoring LFT becomes very important. And one thing about itraconazole is that this has to be given empty stomach. So that is, again, one thing that we have to ensure. And I think the follow-up of these patients is extremely important. Not only from looking at from the point of view of the improvement or deterioration of the patient, but also looking from the point of the side effects of the drugs. So very well said, Dr. Nagarjan. Now, Dr. Paramesh, these patients may come with exacerbation where primarily they would have, breathing difficulty, the worsening of their breathing difficulty. So this could be because of asthma exacerbation or ABPA exacerbation. So how would you differentiate between asthma and ABPA exacerbation? That is point number one. And point number two, how do you treat exacerbation of ABPA?
Yeah, in a non-case of ABPA who is in remission and who has got medical records, it will be easy for us, and most likely our clinical suspicion will be against for an ABP exacerbation rather than an asthma exacerbation. The problem comes when the patient comes in exacerbation for the first time. So at that point of time, we don't have a previous history, and we may not be able to have. Means I'm talking about a patient who is coming to exacerbation into the ED emergency department. As compared to asthma, most of the patients with ABPA in an exacerbation might be having a pulmonary infiltrate. Or a pathognomonic lung infiltration may be seen, or even if they are coming in the first visit, or if the patient is in remission, if the patient's X-ray is clear, and then they come back with another fleeting shadow or pulmonary infiltrate, then we are almost sure that this patient is having an ABP exacerbation rather than asthma exacerbation. You can have a focal finding also clinically as compared in ABP exacerbation, like a focal wheeze or so, and can have, if it is a bronchiectatic segment, you can have bronchial breath sounds on those areas. But in asthma exacerbations, you can either have a silent chest if it is severe, or can have polyphonic wheeze bilaterally. One of the pathognomonic things that differentiates these two is the quality of the mucus plug that the patients might be having. Especially in patients with ABPA with bronchiectasis with a thick mucus as compared to the asthma mucus plug, the excessive mucus production in asthma, the ABPA, the mucus in the ABPA is, as you mentioned, as we all mentioned, the high attenuation mucus, and when you see bronchoscopically, it is a whitish kind of mucus, which is adhered because of the calcium and the other ions which is involved in that mucus. So while managing the exacerbation of ABPA as compared to asthma, more emphasis has to be given to the mucolysis as well as mucolytic agents, as well as drainage of those secretions, especially if they are blocking the segmental or the subsegmental areas. As Matri mentioned, if there is a lobar collapse, then we may need to go in and suck out the phlegm. We can have this bronchial cast and all in certain patients in exacerbations as well. So as compared to asthma exacerbations, one of the major important thing in the management part is the emphasis on mucolysis is what I believe that is the most important thing. And rest of the things, yes, the steroids will be given for both these individuals who are in exacerbation, whether in IP or on an OPD basis, or whether in ICU or in room admission basis. Also, you will be definitely giving bronchodilators as well as systemic corticosteroids. And also we have to look for other secondary infections in both these cases. So this is in short focused discussion about differentiating between asthma as well as ABP exacerbations and management.
Very well said, Dr. Paramesh. And I think one of the criteria could be the measuring the total IG value. So patient coming with exacerbation, the IG level do not rise to more than 40 to 50% from its baseline, then possibly you're dealing with asthma exacerbation.
Asthma exacerbation.
There is no radiological deterioration. So then you can say this is an asthma exacerbation rather than an ABP exacerbation. And of course, first ABP exacerbation you would treat with glucocorticoids, and second onwards you would add itraconazole. I would like to ask Dr. Nagarajun, what is the role of pulse steroid? Have you used pulse steroid in asthma and ABP exacerbation?
So before I answer that question, adding on to the discussion on types of exacerbation. So when a person comes to us with worsening, there are three exacerbations actually. One is the asthma exacerbation, second is ABPA exacerbation, third is the infective exacerbation. So the reason why we have to differentiate them is that if it's only an asthma exacerbation, the duration of steroids has to be only short. You give only for 5 days or 10 days. But if you diagnose it to have an ABPA flare, then as you had rightly said, you have to give a 4 months course of steroid if it's the first exacerbation. If it's an infective flare, obviously it is to do with the infection. And IgE is the most important thing. I think that is the crux. So asthma exacerbation will not have a doubling of IgE, whereas the ABPA flare will have doubling of IgE. Now coming to the role of pulse steroids, so there have been some case series where refractory ABPA exacerbations were treated with pulse steroids, but that is only case series. So if you have to ask me whether I have used them, maybe in a couple of cases, not very regularly, but if the person comes with a very bad asthma exacerbation, not responding to the conventional doses of oral corticosteroids, 2 to 3 days of pulse steroids have been used. That is one. Two, from the discussion with the pediatric experts, there is some pediatric ABPA also has been described. So in their population, what they have resorted to is, instead of giving long-term maintenance oral corticosteroids, they give pulses. They give one pulse, then after 1 month, another 1 day, like that, so as to decrease the cumulative exposure to oral corticosteroids. But this is all, I would say, personal experiences rather than anything else.
Thank you. I think this tells us a lot about the asthma exacerbation and the ABP exacerbation. Of course, the infection has to be taken into account, and most of the time we'll end up giving antibiotics in these patients because you are giving them a high dose of steroids, relatively higher dose of steroids at this point of time. Anyways, now Dr. Shivani Swami, we get you back again. What is the role of anti-Ig and anti-IL-5 therapy in the management of ABPA?
So, sir, when we're talking about the immunological agents, so they are still not mentioned in the guidelines. However, when a patient is having steroid dependence or is having frequent exacerbations, like you said, so maybe, on the first exacerbation, we add steroids. On the second exacerbation, we add antifungals. And if this patient still continues to have frequent exacerbations, that is when a role of these immunological agents has been talked about. So omalizumab is the one from the anti-Ig group that we have. There are multiple papers which have talked about giving omalizumab in these patients. And also there are multiple papers in meta-analysis comparing mepolizumab and benralizumab, which when we actually look at the meta-analysis, more or less have the same effect. However, there is a certain subset which favors benralizumab because, of course, the frequency is much lower. And also there is a hypothesis that benralizumab has a better mucolytic penetration. It penetrates better into the mucus plugs and hence has a better effect in these patients. However, the data is still not very categorically supporting any of these drugs, and still these are not mentioned hence in the guidelines. Also, there are very, very few papers talking about the combination of the anti-IgE, that is omalizumab, and either of these anti-IL-5 agents. But the sample size in these papers is very, very small, around 3 or 4 patients, and I could only find 2 papers. So I think that is also something which needs more data and needs more study before we actually are able to put it into practice. And definitely, I think in an Indian scenario, cost also would play a major role.
Absolutely right. And I think we have been using these drugs off-label and finding them to be quite useful. And of course, as a last resort, at this point of time, when the patient is resistant to treatment, glucocorticosteroid and itraconazole combination, then possibly we have to pitch in and give them a trial for at least 6 months to 1 year. I personally feel if you are trying it biologically, you should try for 1 year because all the trials are showing good response at 1 year. So even after 1 year, the patient does not respond well, then you try to knock these therapies out. But they give us a good alternative, and possibly till we have more data, we can use them anecdotally. in selected
Some
group of
studies also actually, sorry to interrupt, sir, some studies also talk about repeating them because the patient may actually go into clinical remission for a few years. And some studies also talk about repeating these agents after on the next exacerbation.
So still the world has to explore more about that. So coming to Dr. Kamlesh Pandey again. So we have been talking about ABPA with bronchiectasis, with asthma, comorbid conditions. These patients would require supportive therapies for better outcome. Just steroid not going to work, itraconazole is not going to work. So what do you think are the major supportive therapies in these patients? Dr. Kamlesh?
Hello. Yeah.
Yes.
So as you previously said, avoiding exposure to allergen would be the best thing. Then we have already discussed that nebulized anti-amphotericin B again reduces that we have discussed. Inhaled glucocorticosteroids, inhaled corticosteroids to control asthma also is very important in terms of treatment. Then many of these patients have bronchiectasis and they have chronic colonization with pseudomonas. And in such patients, inhaled tobramycin or inhaled antibiotics like inhaled colistin can be considered to reduce the bacterial burden, to reduce the number of exacerbations, and reduce the number of hospitalizations. Then long-term azithromycin has been discussed in management of bronchiectasis that can be considered as a supportive treatment. Vaccination becomes very, very important for all ABPA patients, even uncontrolled asthma patients. Flu, pneumonia, all vaccine becomes very important as a part of supportive treatment. Mucolytics and sputum clearing techniques again to reduce the mucus and viscosity of the mucus becomes important in as a supportive management. And last but very important is pulmonary rehabilitation in any breathless patient with any cause. Pulmonary rehabilitation would be very important to maintain the lung functions and
absolutely
to maintain.
right. Absolutely, Dr. Kamlesh, very well covered. So with continuation to this question, I move on to Dr. Barnali, ma'am. Do you use the hypertonic saline in these patients? Any role of hypertonic saline? Hello? Hello?
You're on mute.
Sorry. Yes, I'm back. So hypertonic saline certainly has very good mucolytic properties that is well known, and therefore it probably does have a role. I haven't used too much of it, but just from that perspective, it should
so
have some
hypertonic saline can be used in patients who got viscid mucus. But there are certain problems with this. The hypertonic saline can induce bronchospasm, and therefore they must be administered after nebulizing with the bronchodilators like salbutamol. And preferably, the first nebulization should be done in the hospital under observation because it can prescribe severe bronchospasm. That is one. And one should avoid the hypertonic saline nebulization in patients who have got FEV1 less than 1.1, less than 1 liter. This is again very important. So it has a role, but it has to be used cautiously. And I think all other aspects of supportive therapy have been very well covered. Would you like to add something on the long-term antibiotic, treatment, Dr. Barnali, in these patients?
Sure. So I think the thing to bear in mind is that if there is bronchiectasis, which is quite established, then there is bound to be pseudomonas at some point. So bronchiectasis, whatever be the cause, it can be ABPA or post-infective or immunoglobulin dependent. So we have to treat the underlying cause, but whenever there is established bronchiectasis, there will be pseudomonas. And pseudomonas, as we know, is a very refractory bacteria. Once it gets in there, it just takes hold. Initially, it colonizes, but then it becomes, it causes recurring infections and causes ongoing progressive lung damage. So I think the pseudomonas, it's important to bear in mind. First isolation of pseudomonas, we ought to attempt to eradicate it using, combination antibiotic. If we have drug sensitivity, then, that's good, but drug resistance is only very common. because there is a limited set of antibiotics. But as pointed out by Dr. Kamlesh, there is certainly a role for nebulized tobramycin for keeping things under abeyance, then azithromycin for its immunomodulatory property to reduce biofilm, the penetration of antibiotics because of the Pseudomonas biofilm, etc. Definitely, these are very relevant. And I think apart from treating the ABPA, I think our focus on bronchiectasis, especially mucus clearance measures and antibiotic treatment, we should be quite aggressive about it.
That's absolutely right, because the European Respiratory Society guidelines advocate long-term antibiotic treatment for adults with bronchiectasis who have frequent exacerbations with 3 or more exacerbations per year. And this would apply in patients with, ABPA who got a bronchiectasis. So very well said. And the role of these nebulized antibiotics and macrolides is important in this group of patients of ABPA as well. Now coming to another little controversial topic, and where there is not much of clarity. And Dr. Nagarajan, this question goes to you. How do you treat patients with asymptomatic ABPA and asthma with aspergillus sensitization?
As you had rightly pointed out yourself, that there is no consensus on this thing. But whatever consensus we could achieve is that asymptomatic ABPA means a well-controlled asthmatic. You don't have to actually treat it. You just treat the asthma and monitor the person. So this is what the current consensus is. Same holds true for asthma with fungal sensitization. As you rightly said, they are at a higher chance of progressing to ABPA. So you would be a little more vigilant in monitoring them, but you would not actively treat them with a course of steroids or a course of antifungal. I think this is what I can tell as far as the two questions are concerned. But we don't know how the evidence will be generated in the next couple of years.
Oh, that's absolutely right. But I would like to know more about asthma with aspergillus sensitization. Suppose the patient is symptomatic. Then what would you do? Would you treat them with antifungal, or we just give them some long-term treatment with corticosteroids? What are you going to do with these patients?
Again, a tough thing, sir. At this point of time, if you ask me, I am not treating them with antifungals. Just treating them as a case of severe asthma and monitoring them frequently with IgE levels to see if they actually develop into full-blown ABPA. But I would be open to a difference in opinion, because this is one area where you don't have any guidelines. I think even the mere existence of that term SAFS is also now being questioned. So I think this is an extremely gray zone.
So I would request that you do your research on two topics. The colonization in ABPA with bronchiectasis and about aspergillus sensitization. So these are the two areas of research for you. Maybe in 2 years I will get some answer from you. Now coming to my last question, we have been through this session for about 2 hours, and we need to complete it. And this is my last question. This goes to Dr. Parmesh, the role of surgery and lung transplant in ABPA.
Role of surgery, ideally, we as physicians should be diagnosing it and may properly treating it, and avoid surgeries in patients with ABPA. But yeah, means bronchoscopic interventions may be required in certain subset of individuals. But if there is an irreversible damage to a certain lobe, and the patient is having recurrent hemoptysis from that segment, then the patients may require a surgical resection or lobectomy or a segmentectomy. But rarely it is possible, because most of the patients would be having extensive or a bilateral bronchiectasis, not a focal disease as far as ABPA is concerned. And as I mentioned, in the later stage of the disease, when the patient has, madam, our radiology discussion went the extensive fibrosis, extensive bronchiectasis, non-functional lung, then lung transplantations can also be tried. But when I search in the literature, I got to see aspergillus and lung transplantation, the aspergillus infections in post-lung transplantation patients. So this question I pass on to the expert, Dr. Nagarjuna Maturu only, to comment and give his final verdict.
Yes, Dr. Nagarjuna, please.
No, I think we only should hope that a person of ABPA should not come to a stage where he requires transplant. The whole point of our webinar is that it shouldn't go to that stage. But then I think, see, if a person progresses, the same criteria for bronchiectasis will apply for ABPA also. There is nothing different. But I'm very sure that all our transplant colleagues have not done a transplant in an ABPA person, at least. To the best I'm aware, in India, at least, there is no person who underwent transplant for ABPA bronchiectasis.
So I totally agree with both of you, and the role of surgery is actually very limited and must be avoided. So even though you've got a focal disease, which is causing complications, surgery, other things, if you remove it surgically, the patient can develop bronchitis in other place also. And you don't want to do surgery repeatedly in these patients. So surgery should be avoided as far as possible because these patients have immunological disease and, it can precipitate the further exacerbation, theoretically at least. Now, coming to lung transplant, doing lung transplant in COPD patient is a little different from lung transplant in asthma patients. Because I feel that COPD is a local disease, where asthma is a systemic disease, where the systemic inflammation, is there, and there is a fear, these patients can develop, the transplant lung can develop, asthma and ABPA later on. So those possibilities are there, and there is no clear-cut answer to that. But possibly these are not the best cases for doing any surgical intervention. So with this, I would like to, conclude that we had a wonderful discussion with the panelists, and personally, it has been a great learning experience for me. What I can understand from the discussion is that the high index of suspicion of ABPA should be maintained in all patients with bronchial asthma, irrespective of the level of control. Of course, patients with severe asthma are likely to have ABPA more, but even controlled asthmatics can develop ABPA, and we must keep ABPA in our radar all the time. The disorders needs to be diagnosed early and treated appropriately to prevent the development of progression of bronchiectasis, which is the biggest complication in these patients. The diagnostic and classification criteria by ISHAM are the criteria that we are following currently and would be followed, and possibly they are going to change in coming days. The best investigation in the diagnosis of ABPA is aspergillus sensitive specific IgE, which can be used for screening. And the most specific and pathognomic finding in CT scan is the hand, that is high attrition mucus, which we all feel that has to be more reported, and radiologists have to be sensitized about. Glucocorticosteroids are the treatment of choice as of now. Antifungal triazoles are used as alternate therapy starting from the second exacerbation. And finally, early diagnosis and appropriate treatment are associated with appropriate outcomes. IgE level, total IgE level would be used more often in following up these patients along with the clinical and radiological improvement or deteriorations. So I think this sums up the whole discussion, and maybe last words from our respected panelists, and then we close from there. Any of you?
I think as far as ABPA is concerned, it's all suspect, screen, diagnose, treat. I think these are the 4 things which we should always remember. You have beautifully covered each and every aspect of diagnosis and treatment. I think those who have stayed in the last 2 hours, I think should be in a better position to manage ABPA.
Yes. And Dr. Barnani, ma'am?
Yeah, no, very little to add. I think we started with 2 excellent lectures, and then we had a very good discussion on ABPA, which obviously has many gray zones and is a topic of great interest to all of us. And the whole session was masterfully conducted by Dr. Manoj Goel, who we know always conducts it extremely well. Thank you very much, sir.
Dr. Parames, any quick word?
Nothing more to add, sir. Thank you, sir, and Amida madam, to giving us this platform to discuss and just share our knowledge and be a better clinician to treat our patients. So I thank you from the bottom of my heart for conducting, and the questions were meticulous, that I would say. And thank you, sir. And thank you, Indian Chess Society, for giving this opportunity. Thanks.
Yeah, Thank you, sir. Thank you. It was an excellent session. I feel like I know a bit more now about ABPA. It was wonderful to interact with you all and the esteemed faculty. It was a great learning experience, sir.
Dr. Shivani.
So, firstly, sir, again, I would really like to thank ICS and especially Amita ma'am for this entire series of webinars. I think that ICS has recently been conducting such relevant topics with such great discussions. And of course, today's webinar was no exception to it. Under your great moderatorship and such esteemed panel, I think the panel was perfect and it has been a great learning experience for myself and I'm sure for the others who've attended as well. So thank you very much again.
So I would like to correct myself a little. I was not the moderator, I was just a facilitator. It's very difficult to moderate the excellent panelists and knowledgeable people like you. And it's been an honor and privilege to listen to all of you. And I really appreciate and thank Dr. Amita Nene for doing this kind of effort. And also thank the Indian Chess Society and Dr. Salvi, Dr. Rajadhar for continuing with these medical education activities. Also thankful to Lupin for giving us the academic support and Imagica Health for providing this platform. Also very much thankful to all the viewers logged in, more than 1,500 logged in viewers, which is amazing, and amazing effort has been done by the organizers. And very grateful to all the viewers who logged in. We regret that we could not answer some of your questions because the time limit, and very thankful for bearing with us for about 2 hours. With this, I conclude and hope to meet you soon. Thank you very much. And I thank you all from my bottom of heart. Thank you so much. Thank you. Have a nice evening. Thank you.
Thank you, sir. Bye-bye.
So with your permission now, shall we conclude this meeting?
Yes.
Thank you.
Yes, thank you so much, Manoj sir. Thank you everyone from Team Lupin.
Thank you. Thank you. Bye. Good
Bye.
night.
Thank you, everyone. Thank you, sir, again. Good night.
Good night.
Yeah. Thank you very much,
Sir,
everyone.
excellent moderation, I should say. And thank you, everybody. Bye-bye. Nice talking.
Bye-bye.
Thank you. Thank you, Matru. Thank you, Shivani. Good night.
Bye. Good night.
Yeah, good night.
Thanks.
Thank you, everyone. So from here, I'm ending this meeting. Thank you. Have a good night.
Thanks, Amaju. Bye. Good night.